Perfect. So I will start with a slow introduction in case anyone else starts to join. And I should probably preface this by saying there's going to be lots of technical details and technical words, which I debated whether to keep in or not, but kind of came to the conclusion that it's probably for your benefit to at least have an understanding of some of the terms in use, so that if you do hear any of the terms bandied about, then hopefully you have a bit of an understanding about what they mean and what they don't mean. So there will be quite a few technical words and some slightly complicated figures, which hopefully we can go through. I'm very happy to take questions at any point, or for you to hold them until the end and then jump back and forth through the slides as you would like. So I've been asked to talk about liquid biopsies for brain tumours, and I thought it's probably useful to talk about what are they, how do they work, why would you have one, and then when potentially could you have one. So that is the plan for the talk. So who am I? So I am a clinical oncology registrar. That means I have done a number of years of general medical training and then have chosen to specialize in clinical oncology. So that is the use of radiotherapy and systemic therapy, so drug treatments to treat cancer. I'm based down in the southeast in South Thames, and I've worked at several centres across those areas. And in my general medical training, I've worked across North London, Sheffield, and originally I trained back down here in Brighton, so I've come full circle. Kind of additionally, I'm currently a PhD student, so I've taken time out of my clinical training to spend most of my time over a 3-year period based in a lab at the University of Sussex, and I will and am investigating extracellular vesicles, and I will explain what those are, as a possible liquid biopsy in glioblastoma. So my main disclosure is that I have a vested interest in one of these techniques. So apologies if I seem to suggest that that is a better technique than others, but that is my area of interest. So I'm sure that you know quite a bit about this. Glioblastomas are common. They're very aggressive, and despite our best and most aggressive treatments of as much surgery as is safe, followed by radiotherapy with a chemotherapy tablet called temozolomide at the same time, and then following it, survival is unfortunately not as good as we would hope. So kind of on average with maximal treatment, people survive about 12 to 15 months after diagnosis. So there's still quite a lot for us to do. One of the challenges with glioblastoma as compared to other cancers, in particular things like breast cancer, is that we don't have any usable subtypes. So for breast cancer, we have lots of well-defined subtypes, whether that's a hormone positive breast cancer, whether that's a HER2 positive breast cancer, or a triple negative breast cancer. We are able to define them with quite a lot of granularity, so we can say this is what sort of cancer you have, these are the sorts of things that drive it, and because we know that, we can target those drivers, and that has led into some really quite targeted and personalized treatments. For brain tumors, we really don't have that degree of knowledge and the ability to do those subtypings. There are a number of, they call them subtypes, which have been proposed in lots of scientific studies, but really those have not made their way into the clinic, and they're not something that I would use in my clinical practice. And there's a number of reasons for that. Oftentimes, there's lots of different forms of the glioblastoma within the same person. We know that it's a really kind of mix of different cells, and even the tumor cells can be quite different from one part to another. We also know that these the tumor will change its subtype over time. It can do it spontaneously, it can do it in response to treatment. And so we don't really have a good ability to split glioblastoma into different groups. And this has an impact on how we potentially could treat people, because if we don't know what might be driving it into one particular group or another, then it means we can't target that driver. We also don't have that many so-called predictive biomarkers. So that is a test which suggests that someone may or may not respond to treatment. We really only have one, and that's the MGMT promoter methylation status, which you may have heard of before. But actually, even with that, there's lots of different ways of testing for it. The tests don't always agree with each other. And sometimes we kind of ignore the test. If someone is very, very fit, we're likely to want to offer them all of the treatment that we can, because we know that the test isn't perfect. After treatment, people then often go into a period of surveillance and have regular MRI scans. And this can be really quite challenging. As you can see in the picture on the right, there are two different tumors, both of which look quite nasty, one of which turned out to be a response to radiation and it got better, and the other one turned out to keep getting worse than we said it was true recurrence. This difficulty in differentiating between true progression and pseudo progression can be really challenging, both for the person who is having the surveillance. It can add a lot of anxiety if it has my tumor really come back, but also for the doctors looking after them, because we don't necessarily know the best option for someone at that time. We then have to do lots of different tests. It takes a lot of time, lots of resource use, lots of appointments coming to hospital. And for the people who it does confirm that someone's cancer has progressed, there is an inherent delay in getting them onto appropriate second-line treatment. If we have to have 2 scans separated by 6 weeks, that's at least an 8-week delay for someone to get onto the second-line treatment. If we think that the treatment's going to work better when the tumor is smaller, which we generally do, then we are providing time for the tumor to get bigger just for us to get certainty, because we really don't have another good option of how to differentiate between these two. Sometimes we can do an operation to confirm one way or the other, but actually that's not very frequently performed. And so we have to rely on the imaging, which, as I mentioned, is quite challenging. The other difficulty with this is that compared to other tumor types, and again, such as breast cancer, where the cancer is quite a lot easier to access, we don't really have as good an understanding of what changes after someone has had treatment to allow us to develop more effective treatments for after the cancer has come back. And whilst there's lots of kind of hope and hype related to different imaging techniques, there's some very fancy radiology pictures down at the bottom, which, if you can see, this area looks like it's got worse, but actually it's dark on some of these other scans, suggesting that it's not as significant of a finding compared to this bottom picture, where it's got a similar brightness, but then does have increasing changes on other scans, suggesting that it is likely to be a true progression. But these scans don't always agree. They're often quite technically challenging to perform, and they're not available everywhere. And so they're still not part of a standard practice. So the reason I've gone through all of this is that really we just need better ways to test and monitor glioblastoma. And so that's hopefully where liquid biopsy techniques come in. So what are they? It's trying to get information about the tumor without having to actually target the tumor. So that's normally by getting a sample of a biofluid, so a biological liquid, whether that's blood, tears, urine, cerebrospinal fluid, lots of different options available to hopefully give us an idea of what's going on within the tumor. And so this slide suggests a number of reasons why liquid biopsy might be better than a standard tissue biopsy. So if it's a blood test, then it's much less invasive, much easier, much simpler, much quicker. It's a lot cheaper than having to hire a neurosurgeon and a neuroanesthetist in an ICU bed to allow us to perform a biopsy. And given that it is hopefully going to pick up kind of all the potential changes, as opposed to a biopsy which just targets a small area, it should hopefully be a little bit more representative of what's actually going on in the majority of the tumor. So there's lots and lots of different sources that we could use for a liquid biopsy. There has been some suggestion that tears and urine could be used, but in general, for brain tumours, the question is, do we go for blood, which is very routinely collected by lots and lots of people internationally? People are very happy and used to providing blood tests, and they're very happy and used to providing repeated blood tests, and we have all the infrastructure set up to allow that, versus cerebrospinal fluid. So cerebrospinal fluid, or CSF, is the fluid that lines and surrounds the brain and goes down into the spinal cord. It has direct contact to the brain, so it might have a greater number of the markers that potentially we would be looking at. It's also a lot less complicated than blood. So blood has a huge number of different proteins, cell types, as well as all the things that we potentially want to be looking at. CSF is mostly just a salty liquid to keep your brain cushioned. And so potentially there'll be a lot less background stuff, and therefore we say that it's got a much greater signal to noise. So a lot less background means a lot less noise, greater contact to the potentially with the brain and to the tumor, so greater signal. But I'm not sure if any of you have ever had a lumbar puncture, so that's generally the technique for accessing the cerebrospinal fluid, but it's not as easy as organizing for a blood test. You have to find someone who can do it, and yes, there are people who can do it, but it still requires space within the hospital. It normally requires at least half an hour lying down after the procedure. We're not as well set up for it. It can be quite a bit more uncomfortable than a blood test. And most people who've had one say that they don't want another one. They would have it if necessary, but it's not as well set up, and people are not as happy to have repeated lumbar punctures as they are to have repeated blood tests. The other challenge is that actually, because they're done a lot less frequently, there isn't stores and stores of CSF in what's called biobanks around the world. There's a little bit, but not a lot. So it's very hard for researchers to develop the test without access to that sample in the first place. So we're in a kind of catch-22 where I'm sure that patients would be willing to have it if it was going to be helpful for them, but we can't prove it's helpful for them without the sample. And to get the sample, we need patients to be willing to have the procedure. So I think, yes, it could be very helpful, and there are ways of accessing CSF. So there's been some people who look at taking CSF at the time of a brain surgery, and that is a valid option to provide additional information at the time of a normal biopsy or brain surgery, but it's probably not going to be the game changer, in my personal opinion, although I'd be very happy to be proved wrong. So there have been a couple of kind of research studies out there which have suggested that liquid biopsies, and generally I'm talking about blood tests now, could be a better way of monitoring glioblastoma. But really, they remain the preserve of individual centres who are experts in looking at that particular marker, and they haven't really been compared to each other. And it's likely, in my opinion, that we'll need more than one of these tests, and that they'll provide additional information to kind of give us enough biological information to try and understand the complexity of glioblastoma, because we know that it's an extremely complex tumor. So what are the standard different types of liquid biopsy? So there's a few kind of flavors out there, and I'll start from the ones which are more common in the literature, although not necessarily for brain tumors, and then I'll go on to the ones which are slightly less common but potentially might be more relevant for people with brain tumors. So the first is looking at circulating DNA, and that could be either cell-free DNA or circulating tumor DNA, and I'll go through the differences. You could look for circulating tumor cells, so that's active cells from the tumor which are in your whichever fluid that you're assessing, generally blood. My area of interest, which is extracellular vesicles, and I'll tell you exactly what those are. And then the other thing that seems to be making a little bit of headway are tumor-educated platelets. You can also look at RNA and proteins from within the blood, and there is some kind of research looking at that, as well as some other techniques which are less developed, and so I won't spend too much time on that unless you had specific questions at the end. So circulating DNA. On the right is a picture of a DNA molecule with the what's called bases, which make up your genetic code. They're grouped into genes, and genes are what provide the details, what I would call the recipe, to get turned into RNA, which gets turned into protein, which is actually what your cells need to make to do anything that it wants to do. So DNA gets turned to RNA, which gets turned to protein, and that's the standard for how your cells get anything done. We know that there can be changes within your DNA, what's called a mutation, and that this happens regularly due to lots of different things, including aging, but is one of the defining features of what we would call a cancer. So these mutations can happen very frequently. There's often lots of different mutations, and we know that in general, different sorts of cancers have different patterns of mutations. So for, say, some types of lung cancer, we know that they could have a mutation in a gene called EGFR. And EGFR is a very strong driver of cells to grow and replicate, and that is therefore a driver of that cell to become a cancer. And so identifying this mutation is a very useful thing to allow us to tell what sort of lung cancer it is, and therefore what treatment to use. We know that mutations happen one after the other, generally, and sometimes more than one at once, but it's a sequential process whereby you go from a normal cell to a slightly unhealthy cell to a cell with lots of mutations to one that can start causing you real problems. And it's at that point that we start calling it a tumor and potentially a cancer, depending on exactly what it looks like and where it is and how it's growing. So this is just to show that you can get multiple mutations, and that different cells can end up with lots of different mutations within them. And actually within a tumor, you can have some cells with mutations A and B, and some cells with mutations B and C, and some cells with mutations A and C, and lots of different permutations thereof, adding to the complexity of all the tumors. So if we know that there are particular changes in DNA. And that's one of the things that we look at when we do a biopsy. And that's become a very standard thing to do when someone has a tumor. We sequence, so try to read what those DNA bases are to see whether there are changes, whether there's a mutation. If we know that those mutations exist, then we can start trying to look for that DNA. And either we can do that in the tumor tissue itself, and that's what has been kind of the standard, or we can look to see if we can find that DNA in other places. And so cell-free DNA, DNA that is now not within a cell, is one of those things. But we know that lots of different cells secrete and push out DNA, which forms cell-free DNA. And so that's both the non-tumor derived cell-free DNA and the tumor derived cell-free DNA. And the tumor derived cell-free DNA is what's called circulating tumor DNA. So that's the difference between CF or cell-free DNA and CT circulating tumor DNA. There are a few ways that we can look at the DNA. One is we can just try to pull out all the DNA and just count how much there is. So there's a few different ways that we can just count how much DNA someone has circulating, say, in their blood. That's really cheap. And in general, we would say that because of the active process of there being a tumor, and because of how actually if the tumor grows beyond its blood supply, it starts dying a little bit, and so it starts breaking up and sending out lots of bits of DNA, we would expect there to be more cell-free DNA in the blood of someone with a cancer than in the blood of someone without a cancer. So potentially that could be a very quick way to say, oh, maybe this person has a cancer. But actually, if we're just counting levels, that's not going to give us that much information, and it won't allow us to do any of the interesting things, say, looking at what sort of cancer, or are there any mutations which make someone's tumor sensitive to a drug. So it's doable, but it's not necessarily the most useful measure. That being said, if you can track levels of the cell-free DNA with treatment, and it goes down after treatment and it goes up again before a scan changes, then maybe that would be a useful monitoring tool. But it won't be that specific. Lots of different things can cause that. But we have had lots and lots of developments in how we can read DNA, so-called sensitive sequencing technology. So putting all the bases of the DNA in order, so they put it in sequence and then they read it. So that's where the term sequencing came from, to find and amplify specific parts of the DNA found in the blood sample. So there's lots and lots of different terms for it, and they mean slightly different things, and they do the sequencing in slightly different ways. And I've just put a variety of the different terms up there for you to be aware that actually all of these are looking to read your DNA in one way or another. So PCR or next-gen sequencing or long-read sequencing or nanopore or whole genome sequencing, these are all different terms for different ways to read different parts or all of your DNA. So if we know what mutation we're expecting to find, i.e. this person looks like they have a lung tumor, and they have lots of brain metastases, then potentially it's going to be a, say, EGFR mutated lung cancer or an ALK mutated lung cancer. And so you can target that gene to see if we can amplify and find that particular mutation. So if you know the particular mutation you think is going to be there, you can look for it. The other option is if we have already got a biopsy of someone's tumor and have found that what their tumor's particular mutations are, you can design a panel to do a similar thing. So if you find that someone has, say, 10 specific mutations, you can look for those 10 mutations. And if you could measure the signal, so the strength of that, of how many of those mutations you find at different time points, you can more sensitively and more accurately measure what might be going on with someone's tumor. So the first one doesn't need a biopsy, the second one would, but the second one is therefore leading to a much more personalized and specific way of monitoring. However, it gets a bit more difficult. So we know that, I mentioned slightly earlier that non-tumor tissue cells can also release DNA into the circulation, into the bloodstream. And so depending on how much DNA is being produced by your tumor, that therefore might be a bit more challenging to pick up. And unfortunately for glioblastoma and other brain tumors, probably due to the blood-brain barrier and maybe other reasons as well, it doesn't seem to release as much DNA as you would have expected for the size and aggressiveness of the tumor. And so it's often really difficult to find that tumor DNA, a needle in a haystack of all the non-tumor DNA that's circulating in your blood. And we know that the main cells that release DNA into the bloodstream are actually your blood cells, so your white blood cells. One thing I have included in the slide, and that's just to add even more complexity and difficulty, is that your white blood cells can often have some mutations in them, which we don't really know if they're going to cause you any problem whatsoever. It's just due to aging or something else. They're called clonal hematopoiesis of indeterminate potential, because we don't really know whether they're important for the development of leukemias or just something that happens with aging. But these white cells develop these mutations, they release the DNA, and you therefore potentially have mutated DNA in your blood, which could look like a cancer, but isn't a cancer, it's from the blood cells. So it makes it quite challenging to really identify whether the DNA you're finding, even the mutations you're finding, are really from the tumor or whether they're just from something else. So from one of the immune cells that's already in your blood and it isn't causing any problems. So for glioblastoma, it looks like it's quite challenging to look for circulating tumor DNA because there's not a lot of it. We don't have the kind of single characteristic driver mutations that you can see with some other tumor types. And so really, we need to look for more advanced methods for detecting DNA from glioblastoma. And there's a couple of ways that kind of seem to be gaining prominence. So the first one is methylation-based profiling. So methylation is where your DNA gets flags put on them to either get them to wrap around the nucleosome, this big kind of purple thing. And if your DNA is wrapped around the nucleosome, which a lot of your DNA is normally, then it makes it very hard for the machinery in your cell to read that DNA and make the protein. So it kind of silences the DNA that's in that area. There are other forms of flagging which can open your DNA and allow the DNA to be read by your cell, but kind of the majority of what's been looked at for biomarker-wise is methylation. And the reason we do that is that it seems like in brain tumors especially, you can have patterns of where the flags are in your DNA. And it seems to be really quite sensitive and specific for different brain tumor types. So the patterns of where these flags are can be really useful for separating out, say, a glioblastoma from a different form of brain tumor, so an oligodendroglioma or an astrocytoma. And there's been quite a lot of work done using methylation profiling, so looking at the pattern of these flags to define different brain tumor types. And there are even some brain tumor types which are purely defined by what the pattern of their methylation flags are. So if we know that there's this characteristic pattern, we can look for that pattern in the circulating blood. And if we find that pattern, then we're much more convinced that the DNA that we're finding is related to the brain tumors. So it's, again, trying to increase the signal to be able to detect it in that, detect that needle within that haystack of straw. The other kind of technique that's is being investigated is fragmentomics. So we know that DNA is huge. So the full DNA for within your single cell, it would stretch way beyond, I think it's something like to the moon and potentially back again. It's really, really long. And so it gets wrapped up. It gets wrapped up around the nucleosomes, around these purple things, and it gets wrapped up into chromosomes in your cell. When it gets released into your bloodstream, it gets released in little tiny fragments. And actually, there's been some nice work done that's looked at the size of these fragments and identified that the fragment size from tumors, and this is specifically brain tumors, is of a different size to non-brain tumors. So again, if you can identify the fragments of DNA that are more likely to come from a brain tumor, it increases your ability to find the DNA information, the genetic information that's from the tumor, and therefore it means that your test becomes a lot more sensitive. So there's quite a lot of work going on to try and make circulating DNA work for brain tumors. It's worked for lots of other different types of cancers, and it's revolutionized how we manage some sorts of cancers, and it looks like it's going to be really quite positive for a lot of different cancers, and so we're trying to bring that into brain tumors. But for one reason or another, it's quite a bit more complicated, and so it's a little bit further behind, but it's still being looked at and it's still being investigated, and it looks reasonably promising. So the next technique is circulating tumor cells. So these are cancer cells that can be identified within the blood. And actually this makes sense. We know that a primary tumor can send off cells into the blood to form a metastasis, a secondary deposit. We've known this for years. It makes sense that there are tumor cells in the blood. But there are not that many of them. It's around 1 to 10 cells per 10 ml of blood. So a normal blood tube is 4 ml. So it's at least 2.5 times that volume, and you may get one tumor cell. And that's compared to the hundreds and thousands of red blood cells and white blood cells in the same volume. And so what you need to do is, again, you need to enrich your sample for the circulating tumor cell. So you're trying to really boost the signal so that you can get useful information. And most of the work that's been done in other tumor types is by looking at a surface molecule called EpCAM. But brain tumors generally don't form metastases. So conceptually, would we expect there to be circulating brain tumor cells in the blood? Maybe not. Occasionally it can form metastases, but that's extremely, extremely rare, generally in people who are very immunosuppressed or immunocompromised for one reason or another. So it could happen, but it doesn't happen as often. And glioblastoma also doesn't have EpCAM on its surface, which means it's really difficult to find these cells if they exist. And so really, looking for circulating tumor cells in glioblastoma hasn't taken off in the same way that it has for other tumor types. And up until recently, that would have been the end of this section, until a recent paper out from a group at Imperial College in London published on a novel method to try and find these circulating tumor cells, or they've called it circulating glial cells, as in from a glioblastoma, in glioblastoma. They've used a special medium, which nobody knows what it is except the company and maybe the team at Imperial, to kill off all the other cells, so that you're all just left with the circulating glial cells. And they did this in a number of different groups of patients with glioblastoma, and also for brain metastases, and also healthy volunteers. And actually, it did look like they were able to find some circulating tumor cells in glioblastoma. So it looks like maybe there is a bit more scope for this technique to be useful. And it's something that I think will start to get more prevalence over the coming years, but it's a lot further behind than some of the other techniques that are being investigated for glioblastoma. So next, extracellular vesicles. I really don't expect you to really process the picture on the side, other than to see that it's actually quite complicated. So extracellular vesicles are tiny little particles, so they're nanometer in size, which is 1/1000th of a 1/1000th of a millimeter. So tiny, very difficult to see, and therefore very difficult to find and study. But because they're so small, they do seem to get out of the blood-brain barrier. So there's lots of different types, as shown in the figure on the right, and they're found in lots of different places. And we know that they can contain lots of different biological chemicals. So whether that's DNA or RNA, and there's lots of different types of RNA, so that's the stepping stone between DNA and proteins, lipids or fats. The cargo, extracellular vesicles have this really quite interesting and potentially quite complicated cargo. They're secreted by all living cells, including cancer cells, and they can transfer their cells from the extracellular vesicles from what's called the parent cell to other cells. And we think that this is a form of cell-to-cell communication. It's how a cell can say, oh, this is going on for me, is this going on for you? And there's a lot of emerging evidence to suggest that this is one way that cancers talk to their surroundings, so-called tumor microenvironment. We know that the area around a cancer is significantly changed to allow and enable the cancer to grow, and grow in a way that often means that it's hiding from the immune system. And there's quite a lot of evidence to suggest that the extracellular vesicles are part of what is affecting this interaction. And it's affecting it in both directions. So the cancer cell to all the other cells around it, the other cells around it to all the other cells around them, the other cells around them back to the cancer cell. It can get quite complicated. But the interesting thing for us is that the cargo of the extracellular vesicles, so what's inside them, does seem to be quite specifically related to what cell they were formed from in the first place. So you can find out what information about the cell of origin, the parent cell, by investigating the extracellular vesicles. So to us, that suggests that you can use what's going on in these extracellular vesicles to tell us about what's going on with the primary tumor. If we can find the tumor-derived extracellular vesicles in the blood, that can tell us what's going on in the tumor. And compared to circulating tumor cells and circulating tumor DNA, extracellular vesicles are present at a much greater concentration in blood. Still not a high concentration, but higher than the other ones. And because of how they are formed, they've got what's called a lipid bilayer, so it's a fatty layer around it. They're a lot more stable as well. So there's a lot more of them, and they seem to last in the blood for a lot longer. So the lab that I'm working on did an initial pilot study, which involved blood samples, plasma samples, so that's a part of blood, from 15 patients with glioblastoma and a matched healthy volunteer cohort. And they found that actually, if you look at the protein contents of the extracellular vesicles from patients with glioblastoma, they're quite different from the protein content of the extracellular vesicles from the healthy volunteers. So if there's a difference, it means that you can use that, what's called a signature. So what are the particular proteins that are present to say potentially say, actually, the extracellular vesicles from this sample look like a brain tumor, and they look like this form of brain tumor. And so you could potentially use that as a biomarker. So that's what my PhD is looking for. We're looking to validate this finding in a much larger group of patients. So we have access to 57 glioblastoma patient samples, which is quite a large cohort for glioblastoma. We have matched healthy volunteers, and we're looking at more of the content, so both protein and RNA, to look at the differences between the glioblastoma patients and the healthy volunteers. And we think this is going to be quite a promising technique, and there are another few labs around the world who are also interested in this same topic, and they also seem to be finding interesting differences between patients with glioblastoma and healthy volunteers. So hopefully watch this space. And then the final type of liquid biopsy that I'd like to talk about is tumor-educated platelets. And platelets are the third type of standard blood cell. So you have your red blood cells, you have your white blood cells, and you have platelets. And your platelets are what stop you bleeding if you cut yourself. They get covered in the sticking plaster of your clotting proteins to kind of stick down on any kind of trauma that you have to stop yourself bleeding. They don't have a nucleus, and that's relevant because they don't have RNA, but they do have some biological molecules, and in particular, they do have RNA, so that intermediate stepping stone between DNA and protein. And surprisingly, the contents, the RNA contents of the platelets seems to be quite different in patients with cancer compared to healthy volunteers. It also seems to be quite different between different types of cancer. So the picture on the right is a representation of what we think might be going on. So the megakaryocyte is the precursor to platelets. So it breaks little bits of itself off. Those are the platelets. And those platelets interact with lots of different molecules secreted by a tumor. So that could be the extracellular vesicles or exosomes. It could be secreted molecules. It could be direct touching of the tumor cell. And it's this interaction which seems to affect what's going on in the RNA inside the platelet. And so primarily investigated by a group in Holland, they showed that by looking at the cargo of what they're calling tumor-educated platelets, so platelets that have been in contact with stuff around a tumor, they can differentiate glioblastoma from brain metastases and from benign brain conditions such as multiple sclerosis. Additionally, when they also used an artificial intelligence to help them process all the complex information, they were able to show that if you have someone after treatment who you're not sure whether their cancer truly is getting worse or whether it's what's the so-called pseudo progression, so it looks worse but actually it's going to get better, they could differentiate between these two groups. So that's a really interesting kind of way of investigating the tumor through its interaction with other cells. But it's still extremely expensive, and it's still really reserved for this one group in Holland. So it's not there yet. But again, it's promising, and it suggests that there are different ways that we can hopefully be making ways forward with liquid biopsies. So those are the kind of the main different topics and types of liquid biopsies. Why, when might they be useful? So pre-diagnosis for either screening or as a method to help with diagnosis. What's called a prognostic biomarker or a predictive biomarker. So prognostic biomarkers are kind of pieces of information which tell you whether someone's likely to do more well or less well, unrelated to the treatment that they're going to have. So is someone likely to have a good prognosis or a less good prognosis? Predictive biomarker is suggesting, is someone likely to respond to treatment A, yes or no? So for brain tumors, the main one that we have is MGMT. If someone has a methylated MGMT, then they're more likely to respond to temozolomide than if they have an unmethylated MGMT, where they're unlikely to respond to temozolomide. So there's a potential that we could use a liquid biopsy to help advise on whether someone's going to respond well to chemotherapy, respond less well, respond well to radiotherapy, respond less well. Monitoring, as I mentioned, it's really quite difficult to look at what's going on after treatment. It can be really quite confusing whether it's pseudoprogression or progression or a treatment effect such as radionecrosis, so where you've given a bit some radiation and the normal cells don't like that and they start breaking down. All three of those can look very, very similar, and it can be very hard to tell what's going on. So potentially liquid biopsies might be useful for that. And then one thing which I haven't really touched on so far, but potentially you could identify patients who are more at risk of developing side effects. So you can predict who might develop a side effect from a treatment, or you could have early detection of the side effect. Say, if you notice that after radiotherapy, a certain change happens in people who are likely to develop kind of memory difficulties, potentially you could pick that up early, and if we can pick people up early, find out what the biological changes are going on, potentially you could offer them treatment or see if you could do something to manage that side effect. So screening diagnosis, for good things, it might lead to early identification of the tumor. It might allow you to say, this is a glioblastoma, this is a brain metastasis, this is an oligodendroglioma, might allow us to identify novel subtypes, which I think is potentially a really interesting thing that we could do. Can we use a liquid biopsy to say, actually, glioblastoma is 3 diseases, 4, 5? Can we use it in that regards? But if we're going to think about screening people, who do we screen? Glioblastoma is rare. We know that these tests, no matter how much we think they're very sensitive and accurate, if you get, say, even 1 in 1,000 false positives, that's much more likely to be a false positive than a true positive if the disease is really rare, such as in glioblastoma. So you have to really know who you're going to screen. If you just try to do this on everyone, I think you'd be drowned out by false positives. You need a way to target it. And actually, we don't really have a way to target it yet for brain tumors. Maybe in people presenting with headaches plus another symptom, you could use it as part of the 2-week wait process. But really, I don't think screening at the moment has as much role to play as for other tumor types. We'd also need to be very, very sure the test is accurate and gives us true information if we're going to avoid a biopsy. So you'd have to have quite a lot of evidence to suggest that that the liquid biopsy is as good as a tissue biopsy before you stop doing the tissue biopsy. So prognostic, identifying who will do well, who will do less well. The question is when to test. There's lots of different times. Is it most relevant what the starting level is? Is it most relevant what the level is after an operation or after radiotherapy? Is it what is the best measure? Is it the absolute level? So if they say go from a 10 to a 1, is that relevant? Is that good? If they go from a 20 to a 1, is that the same as going from a 10 to a 1? Or is it better because it's gone further down? I'm making up numbers, but it's to kind of highlight that actually there's lots of different ways that you could measure the signature and the signal, and how do you measure it most effectively and when to measure it. These are still pieces of information we don't have. And I think a lot of what might come out of it will be just when did someone choose to do the blood test? They chose to do the blood test at this point. This has got some evidence behind it. We'll keep doing that because that's how a lot of things in medicine end up becoming standard. Predictive. Helping to decide if treatment's going to be effective. But really, if a blood test says, well, maybe someone's not going to respond, are we really going to not give someone the treatment which we know does work because a blood test suggests it might not? And actually, there may be lots and lots of good biological reasons why actually that makes sense and we should not give them the treatment and it's just causing side effects without giving any benefit. But again, we'd have to be really confident that we're not going to be doing people a disservice by not giving them a treatment which in general works but might not work in their particular case. We'd have to be really confident about that. Monitoring, so allowing the hopefully earlier and hopefully more accurate detection of a tumor coming back. But again, it's who to screen, when to screen, and how confident are you that the test is correct. So if the test suggests that actually it is the tumor progressing, but the scan looks indeterminate, which one are you going to believe? You'd have to have quite a lot of evidence to say we are happy and confident that the blood test is giving us the right information. And side effects. So better management of side effects. If we can pick a side effect up early, we can say stop the treatment that's causing it, implement management to try and help support or prevent it getting worse. You could even tailor your treatment based on who's likely to develop a side effect. So if a pre-treatment blood test said, oh, this person's very, very likely to develop memory issues soon after treatment, that might have some influence on them deciding whether they're willing and wanting to have that treatment. But the big question is a blood test actually going to be able to give us any of the information to suggest that we can pick up these changes? And there's a bit of a suggestion in the scientific literature that maybe it could. There's some hypotheses, so we think that maybe it could, but we don't know that yet. It's still pretty early days. And so when might you be able to have a liquid biopsy? So unfortunately, it's not yet, unless you happen to be in a research study. But even if you're in a research study involved with liquid biopsies, because of how early it is in the development process, they're unlikely to give you much of the information back in a timely fashion or at all. So because most of the techniques are still in a very, very early discovery or developmental phase, we're still just trying to work out if it's feasible, let alone if it's effective. So there's still quite a lot of work to do to optimize and develop these processes. Currently, most of the tests are only used in a small number of patients, generally at one center, to see if they are providing any signal that they might be useful, such as, and really we'd want that to be confirmed in much larger studies. And if we're going to use it to kind of adjust people's treatment, really you want to have a probably a randomized trial randomizing people to standard of care versus using the results of the test to kind of say go for treatment A or treatment B. And that's going to be quite a long way away, unfortunately. And so probably we're still looking at in the order of years before these tests are routinely available. But we will see. So what can you do to help? Well, if this is something of interest to you, then if there are research studies available to you, then please do feel interested and able to consent to the research studies to provide your samples, even if it's just to be stored in a biobank, because without biobanks of samples, then researchers can't access samples to even start to develop these tests. And then working with charities to provide expert patient knowledge for researchers who are trying to work up applications to funding bodies to study liquid biopsies, providing advice directly to the researchers looking to develop these processes, either as part of the project development or as part of funding review panels, and just pushing your local teams and your kind of political members of parliament and council members to try and push for brain tumor research and liquid biopsy research as much as possible. So I'm very happy to answer any questions or hear any feedback or thoughts that you may have. Alison, I see your hand has come up at the perfect timing, but you're muted. Oh, you're still muted, Alison. That's better.
Thank you. Yes, that was very interesting, Stephen. Thank you. Your slide but one, providing
that one or the one before?
No, the one after that.
This one?
Yeah, consent to research studies to provide samples. How can you do that if there isn't a sample, but if they're not taking samples?
So
that's a chicken and egg, isn't it?
So they're not taking CSF samples because nobody's having CSF. There are several places in the country which are trying to develop biobanks, whether that's for the primary brain tumor tissue, and there are also places which are trying to develop so-called liquid biobanks, where they store patients' blood samples at defined time points, and that's whether for a defined research study at the time or for kind of future unspecified research uses. So one of the things I'm trying to set up down here is the routine collection of kind of effectively excess samples for future research, because I've spoken to several people with brain tumors and their kind of relatives, and spoken to several people through the Prime network, and everyone is always really keen and interested to provide samples, but we don't necessarily have the process set up. So I'm trying to set up that locally, and I know that there are several places around the country which are routinely collecting samples. But the other option is to push your consultants to say, are you collecting samples? Can you collect samples? Can you help support me provide samples for research purposes? And it might be...
Sorry, I interrupted you. Go on.
And it might be that they can ask one of the, say, potentially larger centres around you whether they'd be willing to collect your samples kind of as a research referral. But given the kind of workload and stresses of the NHS, I think without patient pressure to develop these services and charity pressure to develop these services, it's going to be a bit more challenging to get it routine. So there have been a number of kind of publications out, including from the charitable bodies, that actually we should be collecting more samples, mostly tumor samples, for research purposes, and that it's something that we should be really trying to set up everywhere. So I think I would push for blood samples to be included in that routine collection, and that we really need to be pushing to develop these services across the country.
Right. Okay. I think blood samples is doable. My tumor is growing around the motor cortex area, so a biopsy would not be feasible. I had tried to have an operation, Paul Grundy, I don't know if you've heard of him. He tried to do it and he had to go 3 times under the same anesthetic. He tried to go 3 times with it and I kept fitting. But that was my choice because I just wanted the damn thing out and carry on my life. And he thought I was mad, but I just wanted to go back to what I was doing. And in the end, he couldn't do it.
And I know that Paul is very pro shared decision making and supporting patients to make the decision that's right for them. So that fits with what I would expect from Paul. He's very good like that. And I know that Southampton has a biobank for tumor tissue, and I think they might be developing blood sample collection. So it might be worth asking them, and it might be that enough pressure from patients will get them to do it quicker, or it might be that they have it for certain situations and you could potentially kind of see if you can count as an extra to provide your samples.
Right. Okay. All right. Thank you very much, Stephen. Thank you for that. Next time I see my consultant, that'll be November. I'll nobble him.
Are there any questions from anyone else? I've got a question, Stephen.
Yeah.
We talked a lot about what the opportunities are for people that have glioblastoma, but is there any scope for liquid biopsies to support people with different types of tumours, and how would you expect that to look, if so?
Absolutely. So glioblastoma being the most common adult brain tumor is what kind of most of the focus on it has been on, but some of the studies have kind of looked at different forms of brain tumors, so looking at grade 4 versus grade 3 versus grade 2, and there do seem to be changes and differences suggesting that you can use liquid biopsies for kind of deriving the brain tumor typing information potentially, and the kind of when you might have them would be very similar. So pre-diagnostic or kind of with the diagnosis to provide prognostic or predictive information or for monitoring purposes. And I know that some centres are looking at it for the non-glioblastoma primary brain tumours, and there's also kind of a developing interest in using liquid biopsy techniques for brain metastases. So brain metastases, similarly to primary brain tumours, the circulating tumor DNA and circulating tumor cells seem to be slightly less effective than you would expect from the non-brain metastases setting. And one of the thoughts is that, again, possibly because of the blood-brain barrier, that the circulating tumor cells from any systemic metastases or primary tumor, or circulating DNA from the systemic metastases or primary tumor, is effectively overwhelming the brain metastases signal, making it much more difficult to identify. And so that's why potentially some of the other more novel techniques might be more useful in the brain metastases setting as well. And that's something that we are looking to investigate ourselves with the extracellular vesicles.
Well, thank you so much, Stephen. Thank you so much for the whole talk as well. I think you so eloquently explained something that people have been trying to get their head around for a long time. You know, it's something that I've spent a lot of time reading and writing about, but I've never understood it as well. So I appreciate that so much.
No, me neither. quite a complicated topic with quite a lot of complicated words, which can seem like a real barrier to even starting to understand. So hopefully I've been able to try and break apart some of that jargon to make it a bit more understandable.
Yeah, unravel it a bit.
Yeah. And just suggest why it might be interesting and useful, and why I think we should be doing at least sample collection a lot more routinely.
Yeah, absolutely. Yeah, thanks so much. I think, you know, if nobody else has any questions, we can wrap it up. And thanks for letting us record this too, because I think this will be really valuable to keep and signpost to. You know, this can be like a living resource that we signpost to for anybody that's got similar kind of interests or questions, which I'm sure you know, over the years we will have.
Stephen, is there a difference between the most dangerous and the most not dangerous tumours to have? Like
There seem to be.
Like I've got an astrocytoma compared to a GBM. And I know somebody in Oxford is going through, he's got an oleoglioglendroma. I mean, can you rank them in terms of 1 to 5 as to which is, I know there's hundreds of different types of tumours, but which are the worst and which are the best, if you can say that, best ones to have?
So I think if
you're looking at, to say?
If you're looking at median survival, which kind of is a surrogate for that, then we know that unfortunately glioblastoma has a very short median survival of about 12 to 15 months. We know that astrocytomas, depending on whether it's grade 2 to grade 4, kind of spans somewhere between